if you want. Now, when you look at someone's skull, if you open it up, you're going to find a huge cavity on the inside, right? So if you took if you remove the top of someone's skull like this, inside you're going to see a huge cavity, and that's the cranial cavity, and of course that's where your brain is going to be. But there's also a bunch of smaller cavities to be aware of. There's your nasal cavity, right, which is the inside of your nose. There's the orbits, which are your eye sockets. The paranasal sinuses, those are the guys that a lot of people have trouble with, right? Anyone here have sinus problems or sinus headaches or anything? Those are the paranasal sinuses. Those are inside some of your skull bones. There's basically 4 skull bones that have these sinuses, and I'll go through that in a second. And then you also have some smaller cavities deep inside, like your inner ear, where you have like the things that are involved in hearing and equilibrium. So you can break down your skull into 2 groups. You're either a cranial bone or you're a facial bone. Cranial bones surround and protect the brain. The facial bones make up your face. Notice these numbers that are off to the sides of each of these things. What do those numbers mean, do you suppose? Yeah, how many of them you have, right? And if it says number 2 up there, that's going to mean that you have what? 1 on each side. You'll have a left and a right, okay? And if it says 1, what does that mean? It usually means it's in the middle, right? So just bear that in mind. Just glancing at this, you may notice that most of the cranial bones, there's just 1 of them. With the exception of these 2 guys, the other ones all just have 1 of them, which means they're right in the midline. Versus when you look at the facial bones, it's really only the mandible and this weird one called vomer that have just 1. All the other ones are going to have a left and a right side to it. Okay. All right, so this is showing you some of the cranial bones. The bone that forms your forehead is the frontal bone. Just behind that, you have a pair of parietal bones, left and right parietal bones. On the side of your head, you have a left and right temporal bone. And then at the very back of your head, you have an occipital bone. Those words, frontal, parietal, temporal, occipital, those words are going to come up also when we discuss what in the class? Anyone know? Frontal, parietal, temporal, and occipital. Anyone know? When we talk about the brain, okay, the brain has different lobes to it, and those lobes of the brain are named basically for the bone that's kind of on top of that area of the brain. So there's a frontal lobe, there's a parietal lobe to the brain, a temporal lobe, and an occipital lobe, okay? 2 other cranial bones that are hard to see from the outside, the sphenoid bone and the ethmoid bone. The best way to see those bones is if you like remove the top of the skull and kind of look down from above, and I'll show you that here in a moment. The spot where one cranial bone connects with another cranial bone is called a suture. And a suture is a joint. What's the definition of a joint? It's just a spot where 2 bones meet. It's just a connection between 2 bones. However, if I were to ask you, name a joint, so someone name a joint. What'd you say, knee? All right, someone name another joint. Elbow, okay? Most of the time, shoulder. Most of the time when people think of joints, they think of joints that move, right? Your knee joint, or your elbow joint, or your shoulder joint, right? They all move. But that's not the definition of a joint. A joint is strictly a spot where 2 bones come together. There's no rule that says they have to move, and the suture is a good example of that. Suture is an immovable joint between your cranial bones. And you have a couple of different sutures that you're going to need to know. The coronal suture is what connects the frontal bone with the parietal bone. There's a sagittal suture that's right in the midline that connects the 2 parietal bones, but you can't see it in this view. On the side of your head is the squamous suture, which would be this line here, that connects the parietal bone with the temporal bone. And then at the very back, that connects the occipital bone to the parietal and to the temporal is this thing called the lambdoidal suture. And there's a little fun sort of history on on that. Well, fun for me, probably just extra extra lecture for you guys. Anyone here ever been in a fraternity or sorority? No? This is what happened in the first class. No one joined a fraternity or sorority. All right, fine. Is anyone in here aware of Greek letters?
Yes.
Okay. That helps. You don't have to be in a fraternity or sorority. But one of the Greek letters is called a lambda. Okay? And if you look at that lambdoidal suture, I'm going to try to hold this together and show you at the same time. It's a little hard to see maybe, but it's shown here in yellow. The lambdoidal suture actually looks like this. It goes up and then it comes back down, and that's because, here's the history lesson, this is what a Greek lambda looks like. Okay, so that's how it got its name, lambdoidal suture. Okay? I hope you're paying attention. There's going to be 100 questions about that on the next lecture exam. No, I'm kidding. 99 maybe, not 100. All right. Soft spots, these are things you find in babies' heads. Everyone aware that babies have like soft spots, and you got to be careful when you handle a baby. You don't want to really press on anything, right? Anyway, these are the soft spots. These represent areas where the bones haven't connected yet, areas where the sutures haven't closed yet. And there's 4 of them. The biggest one is called the anterior fontanelle. Then you have 2 on the sides, an anterolateral fontanelle and a posterolateral fontanelle. And then you have 1 in the very back called just the posterior fontanelle. Okay? These things are really important to stay this way when you're a baby because they allow the skull to expand as the brain is growing. Okay? The brain is getting physically larger in a young baby, and in order to facilitate that, you've got to make sure that the skull is still getting larger. Once those sutures formed, it's like game over, right? You're not going to be able to get a bigger brain without starting to cause brain damage, right? So that's the purpose of these fontanelles, is to allow the skull to expand as the brain is growing. Eventually they should close. All 4 of them should close by 2 years of age, okay? The last one to close, just because it's the biggest, is that anterior fontanelle, okay? And yes, we do have a baby skull. No, I don't know where it came from. Yes, it's real. Any other questions you want to ask? I don't know. I'm trying to put all the disclaimers out before I even get started. This is a baby, it's kind of creepy. It is a baby skull. It's kind of cute. I don't know. It's like Mudang or whatever. No, I'm just kidding. And then you've got, right here, you got the soft spot. You can see there's the anterior fontanelle, and it's still pretty big on this skull. The other ones have kind of started to close. It looks like over here would be the anterolateral fontanelle. There would be the posterior lateral fontanelle. You can barely see them. And then back here in the middle would be the posterior fontanelle. They look like they're pretty close to closing, but this one is still open.
Would that be soft bone?
Would it be soft bone?
Yes, like those,
Those fontanelles?
Yes.
It's not even bone tissue. It's more like tendons and ligament type tissue. It's not bone tissue.
Okay.
Yeah. Let me put this away before I drop it. This is very fragile too. You can see it's been cracked a couple of times, so I'll put this back. That's mine. Now, there are 2 weird bones, 2 weird cranial bones that are hard to see from the outside. I'll show you a better picture in a second, but those are the ethmoid bone and the sphenoid bone. They're kind of strange. Speaking of the ethmoid bone and the sphenoid bone, let me talk about the paranasal sinuses. So these are cavities that are inside 4 of your skull bones. So if you're counting, the ethmoid bone has little cavities called the ethmoid sinus in it. The sphenoid has little cavities called the sphenoid sinus. The frontal bone, where your forehead is, right about here, you have a frontal sinus. And then lastly, on your maxilla, which is right here, you've got a maxillary sinus. So those are the 4 paranasal sinuses. And this is what they look like if you could see them. You can't see them because they're inside the bone, but if you could see where they were, this is their rough location on an anterior view. You can see this is the big frontal sinus that's up in the frontal bone. That's the big maxillary sinus. And then the sphenoid and the ethmoid sinus, they're a little bit deeper into your skull. They're probably better to see on a lateral view and not on front view like this. Okay? These, sinuses give people a lot of problems, and that's because the sinuses are connected up with your nasal cavity. There's little passageways that connect all of these paranasal sinuses with the inside of your nose. So when you have a cold, right, the cold can start out in your nose, or maybe it starts out in the back of your throat, but it's real easy for the virus or the bacteria or whatever to crawl its way along those little passageways, and next thing you know, the infection has extended into the sinuses. And those sinuses can fill up with inflammatory fluid and gunk and mucus and whatnot, and that can definitely like change the sound of your voice when that happens, and it causes pressure and pain, okay, when they start to fill up too. Why do we have these paranasal sinuses? They don't know for sure, but they have some ideas. One belief is that the paranasal sinuses help humidify and warm the air. So all of those sinuses are lined with mucous membranes, and when you inhale through your nose, the air will go into those sinuses through that little passageway, and the mucous membranes that are there, the blood vessels that are there, they will help humidify the air, and they'll help to warm up the air. So that's one possibility. I mentioned before how your voice can change when you have a cold going on. Having hollow spaces in your face, and it acts like almost like an amplifier for your voice. And when they start to fill up with fluid, you lose kind of that resonance in your voice, and your voice doesn't sound the same. Okay? And then this cracks me up. The other proposed reason why we have these sinuses is simply to reduce the weight at the front of your head, right? Like if, again, they don't know this for sure, but the theory is like if these things were filled in with bone, if they were solid, the front of your head would be just like too heavy. You'd be like this all the time. Your friends would be like, you want to go out? Like, I just don't feel like raising my head today. I'm sorry. I can't do it. I don't know. It's just a theory. My head's too, once again, my head's too heavy. I just can't take it. Gotta take a rain check. Here is a better view to show you the sphenoid and the ethmoid bone. So cut off the top of the skull and then look down from above, and you get a really good view of the sphenoid shown in green there. If you're like most people, or a lot of people, you look at that and you'll say it kind of looks like a bat shape, okay? That's how the sphenoid is usually described. On a surface, but on a view from above, it kind of looks like a bat. On a view from the front, if you could see the sphenoid bone looking front on, it looks more like this, and then it's kind of described as like a moth type of appearance. Okay. The ethmoid bone sits anterior to it, and it's got a very strange shape to it. Now, the sphenoid bone is arguably the most important cranial bone because it holds all the other cranial bones together. It's the only cranial bone that touches all the other cranial bones, or connects with all the other cranial bones. So if you look at it, and if you kind of think of this as a clock, and you start at 12 o'clock, you can see that the sphenoid forms a little joint with the ethmoid bone. Then as you work your way around the clock, it forms a joint with the frontal bone. Then as you go around to like 3 o'clock or something, right here, it's not big, but it's still connected. You see a connection between the sphenoid and the parietal bone. Then as you come back here, there's a big connection between the sphenoid and the temporal bone. And then as you come back here, there's a connection between the sphenoid and the occipital bone. And then as you go around, it just basically repeats itself. So someone at some point thought that they would refer to this as the keystone of the cranial floor. Keystone is like an architectural term. I'm not an architect, but I guess, I don't know, in architecture terms, like sometimes there's one particular brick or something that's kind of holding it all together. And so, I don't know, that's how they got this name. Facial bones, I'm not going to go through all the facial bones. There's a lot of them. You will eventually have to know them, and I will go over them in lab next week. I'll do a review at the end of lab next week and show you all these bones. Most of them are going to be classified as irregular bones because they have weird shapes to them. You can see all the crazy names up there. The only two unpaired facial bones are this weird guy, vomer, that's right in the middle of your nose, and then your mandible, which is your jawbone. Okay, those are the only unpaired ones. What's that?
Is it like right here or?
So vomer, if you put your fingers in your nose, go ahead, I'll wait. You put your fingers in your nose, when your fingers first go in your nose, it's going to be cartilage, right? You're going to be able to bend back and forth. But if you keep going and keep pushing your fingers far enough back, eventually it becomes bone, and that's when you would feel vomer. So it's part of the septum, it's part of the bony divider between your right and left nostril. Besides protecting the brain, the skull provides a framework for attachment of muscles that move various parts of the head. So, you know, we'll talk about all those different muscles when we get to that chapter. But for example, you have a big muscle that comes across in your neck here called the sternocleidomastoid muscle. And it attaches basically to a spot on your temporal bone behind your ear and causes you to kind of turn your neck to the side. We'll discuss all that stuff. The skull is also an attachment point for your muscles that do facial expression. So when you smile or when you frown or whatever you're doing with your face, it's because of the little muscles that are in your face contracting. And one end of those muscles is going to be attached to the facial bones. The other end of the muscle is actually attached to the dermis of the skin on your face. So when you contract it, it pulls your skin and it causes you to smile or frown or pout or whatever. All facial expressions that I've seen in A&P. All right. Moving right along. Hyoid bone. All right, we're finally out of the skull. So hyoid bone is this weird bone that doesn't form a joint with any other bone in the body. It's kind of hanging up high in your neck. It's not shown here. It's not shown in this diagram, but there are muscles from above that are kind of attaching to it, and that's what's suspending it up there. It's a really important attachment point for some of your tongue muscles, okay? As well as ones that are in the pharynx. So, you know, all the complex movements that you do with your tongue, a lot of those come from the attachment to the hyoid bone or swallowing movements, things like that. We'll talk more about that in A&P2 when we do the digestive system, but that's an attachment point for it. It's got kind of a weird shape to it. It sort of looks like a horseshoe shape to it. So, forensically, it's a bone that they'll look for in criminal cases because I think like 80% of the time in strangulations it does get fractured. Okay, so bear that in mind if you're thinking about, you know, doing it that way or something. Just put a pillow over someone's mouth and nose. You don't want to touch down here. Just do it like this.
So is it easily broken, or does it actually take force?
No, it takes a fair amount of force. Yeah, it's not going to just snap on. Like, but if someone's like doing this to your neck, yeah, it'll break. Yeah. All right. Finally, we're on to the vertebral column, which is basically your backbone. It's made up of these individual bones called vertebrae. This is what a typical vertebrae looks like from above, kind of looking down on it. There's three parts to a vertebrae. The big obvious part that you see, that's called the vertebral body, and it's the part that bears the weight, okay? It's big, it's thick, and when you're sitting or when you're standing, all of your body weight is basically going down through those vertebral bodies. And that's why, you know, when I showed you on Tuesday's lecture, I showed you like the compression fractures that like the woman got with osteoporosis, right? That's because it's basically the vertebral body just collapsing from too much weight and from the osteoporosis that was affecting the vertebral body. The next part of it is called the vertebral arch. So this is the body, and then going across like that would be the vertebral arch. The vertebral arch is made up of two parts. You've got a pedicle here, then you've got a lamina, then you've got another lamina, and then you've got another pedicle. So together that forms the arch. And then coming off of the arch are 7 different processes, okay? The biggest one, the one that's most obvious, is the one I talked about before, the spinous process, and that's going posteriorly. But then you also have these 2 processes on the side called transverse processes that go out to the left and to the right. You then have 2 processes that go upward, so they're kind of coming out towards you in this diagram. Those would be the superior articular processes. And then you can't see it on this view, but there's also 2 processes that are going downward, and those are called the inferior articular processes. So if you were to count these, you'd have 7 total, right? 1, 2, 3, 4, 5, and then the ones you can't see, 6, 7. Now, there's the different regions, though, that you're going to need to know. Cervical, thoracic, lumbar, and then sacrum and coccyx. And there's a certain number of vertebrae in each region. So there's 7 cervical, 12 thoracic, 5 lumbar. And you can see that they're usually named by taking the first letter of the area and then putting a number with it. So C1, C2, C3, or T1, T2, et cetera, et cetera. For the most part, like in lab, I am going to ask you to tell me where a vertebrae came from. Like, you'll have to tell, is it cervical, is it thoracic, or is it lumbar? You will have to tell me that. But for the most part, you won't have to give me like the specific number. I'm not going to make you look at a thoracic vertebrae and be like, oh, that's T8, or oh, that's, L3, or anything like that. You don't need that level of detail, but you do need to know the area that it comes from. So, again, if you look at an individual vertebrae, in the middle of the vertebrae is the vertebral foramen, and that would be where you find the spinal cord. And then when you stack vertebrae together, you create holes on the sides that are called intervertebral foramen, and those basically represent holes so that the spinal nerves, which are connected to the spinal cord, can basically exit and then travel to different parts of the body. Okay. Now, the joints that you have between your vertebrae, a portion of the bone of one vertebrae will form a joint with the bone of the other vertebrae. But most of the weight that's coming through is not a bone-to-bone connection. Instead, you've got a piece of cartilage in between. So in between the vertebral bodies, and that's where all the weight's coming, are going to be these discs that are made of fibrocartilage. Okay? Anyone remember the claim? There were 3 types of cartilage, right? Fibrocartilage, hyaline cartilage, and elastic cartilage. Anyone remember the claim to fame for fibrocartilage?
Yeah, it's only your discs, I think.
No, it was the whattest type of cartilage. It's the strongest type of cartilage. So it makes sense that that's the type of cartilage you'd want as these discs, right? Because all of your body weight is coming down through them. So they're very strong. I'm going to talk more about the discs at the end. I want to talk about a herniated disc, so I'll come back to these guys later. But just know that they're very strong. Now, if you look at someone's backbone or vertebral column from the side, you should see 4 curves. Right? So you're looking at somebody's backbone from the side, there should be 4 curves to it. And those curves are color-coded in number up there. So the curve in the neck area is called the cervical curvature. Then you got the thoracic curvature, then the lumbar curvature, and then purple you have the sacral curvature. 4 curves in an adult. When you're a newborn, you just have one kind of big curve. You can still divide the areas up, but they're all curving in the same direction, right? Now, what's going to have to happen, though, obviously, after you're born, you're going to be born having this kind of a looking spine, but it's going to have to eventually look like this. And if you look at the direction of the curves, some of the curves are going to stay the same direction in the adult that they were in the baby, and some of the curves are going to change their direction. So let me tell you what I mean by that. If you look at the thoracic area, which is in blue, and you look at the sacral area, which is in purple, they are concave relative to the front of the body. And if you go back to a newborn, they're still concave relative to the front of the body. In other words, they don't change their direction. They're concave when you're a baby, and they're also in the concave direction when you're an adult. So they call the thoracic and the sacral curves, they call those the primary curves because they don't change their direction. Whereas if you look at the other 2 curves, the cervical and the lumbar, they start out being concave, But then in an adult spine, they've changed their direction, and now they're convex relative to the front of the body. And because they've changed their direction, they refer to those as the secondary curves. My question to you is, what happens to make those curves change? What causes the cervical curvature to change from this to that? Who gets stronger? Babies get stronger, and they can start to do what? They start to look around. They start to get enough strength in their neck to like look around and be like, what the hell's going on, right? They're lifted. Once they get strength to start lifting their head up, and you got to remember, babies' heads are huge. But 1/4 of the baby's height is their head. So it takes a lot of neck strength to start doing that. But once they get that neck strength, then gradually this will change from this to starting to be sort of convex like it is in an adult. So that's what changes that. What changes the lumbar one?
Is it walking?
Well, when they start getting able to sit up, right? As soon as they start being able to sit up, then this curve will change and become more like that, okay? This is basically just repeating all the stuff I said, so I'm just gonna skip over this. And then this slide is a pretty good slide to look at for lab purposes. This shows you the differences between the cervical, thoracic, and lumbar vertebrae. And this could help you like during a lab situation where you have to tell them apart. So I'm not going to go through every detail on here, but let me tell you some of the things I think are the most obvious about these things. First of all, just size. Cervical are the smallest, then thoracic are a little bit bigger, and then the biggest are the lumbar. Why are the lumbar ones bigger?
Probably bear the most pressure.
Yeah, they're bearing more body weight, right? When you're a cervical vertebrae, you just kind of have to hold up the weight of your head, right? But as you go down, it's cumulative, and you keep adding more and more weight, so it makes sense that the lower you go, the bigger the vertebral body has to be, right? Now, when you're looking at cervical, there's some things that are really obvious about cervical that set it apart. And one of the most obvious things is that they have 3 holes, okay? They have the big vertebral foramen that everybody has, but then they have these 2 additional holes that are in the transverse processes. So as soon as you see 3 holes like that, you know your work's done. You'll be like, that's a cervical vertebrae, okay? Another thing that can sometimes set cervical vertebrae apart is if you look at the spinous process, it's often forked like that, okay? Versus the other ones won't be forked. That's called a bifid spinous process. Thoracic, how do you tell thoracic? Well, first of all, you know it's not cervical because you don't see the extra holes, so you've ruled that out. But like, how do you tell thoracic from like lumbar? It's a little hard to see on this view. I'll show you some better views in a second, but if you look at a sideways view of a thoracic, there's little indentations on the transverse process here and there, and then there's also little indentations on the vertebral body part, like here and there. Anyone know what connects to the thoracic vertebrae that doesn't connect to any other vertebrae? Ribs. Those are the spots where the ribs are forming joints with the thoracic vertebrae. There's little indentations there. No other vertebrae connects to ribs, so no other vertebrae is going to have those little indentations. So if you see those right away, then you know that's thoracic. And then, you know, basically, if you've ruled out all those other features, you can probably guess that it's going to be lumbar. Lumbar ones are huge. They got a huge vertebral body. They're really big that way. Another thing that a student showed me, it's a fun thing, hold on. I'm always learning from my students. See, it's a 2-way street. I give you some information, you give me some information. It's quid pro quo. Hold on. This is so dumb, but I loved it. When she showed it, I don't know if she read it in a book or where the hell she got this from, but it was pretty clever. I'm not sure that this will really help you like during a practical, but anyway. Here's a thoracic vertebrae, okay? Here's a lumbar vertebrae, okay? If you look at them from a certain angle like this, right? This looks like a giraffe, and this looks like a moose, all right? So giraffe is thoracic, moose is lumbar, all right? I don't know how they figured that out. It was pretty clever. I gotta give them props. All right.
Great, now I can't unsee it.
All right. Now, the cervical vertebrae. There are two special vertebrae that you should be able to recognize. I just got done telling you you're not going to have to tell me like T4 or L3, but there are two specific vertebrae that have such a unique shape that you should know them. And those are your first two cervical vertebrae, C1 and C2, and they even have special names for them. C1 is called the atlas, C2 is called the axis. And C1, the special shape for C1 is it's basically just a ring. There's no spinous process coming off the back. It's just a ring, okay? No other vertebrae looks like that with having just this ring. Whereas C2 has a special thing on it that protrudes upward, and that's called the dens. No other vertebrae has that. Now,
Can you feel your C1?
what's that?
Can you feel your C1, I presume? Or?
Not really. I mean, if you're pushing hard, yeah, I guess you're feeling, like if you feel where you're starting to feel the bumps on your neck, you're feeling the spinous process of C2, but if you go right above that, you can kind of feel where C1 would be, right? Unfortunately, I don't have a model here of C1. They're kind of a hot commodity, like A&P teachers steal them because they know there's so few of them, and I didn't steal fast enough this morning. I apologize. I will try to steal better next time. I do have C2 though. Here's C2, and this weird little thing that's protruding upward, that's the dens, okay? There's no other vertebrae that looks like that. These are important vertebrae for moving your head, okay? When you go yes, like yes, I'm gonna pass, right? When you go yes, it's basically, it would really help if I had a C1, but I don't. So I'm gonna have to use a different vertebrae to kind of pretend like it's C1. So when you go yes, you're using something called the atlanto-occipital joint. That's the joint between the atlas, which is C1, and then the occipital bone, which is one of your skull bones. So if you look at the bottom of your skull, this is the occipital bone, and on the occipital bone are these little rounded surfaces called the occipital condyles. And they're kind of like the feet on a rocking chair. And those occipital condyles will actually sit right on these little indentations that are on C1. And again, this isn't actually C1, but I can still use it. So it kind of sits there, and when you do yes, you just rock back and forth on that. So that's the atlanto-occipital joint. It allows you to do yes. That's not the same joint, though, that allows you to do no. The no joint is the joint between C1 and C2. That's called the atlanto-axial joint. And when you do no, you're spinning this ring, C1, around that weird dens of C2. That's what does the no move. Okay. All right, thoracic vertebrae, this is a much better picture to illustrate what I was talking about. If you look at thoracic vertebrae from the sides, you'll see these little extra indentations. And those are the indentations for where the ribs are going to connect. There's 12 thoracic vertebrae, and there's 12 pairs of ribs. So it makes sense, right? Finally, you have the lumbar vertebrae. They're going to have big vertebral bodies. They're going to be really strong, stout looking. And, just remember the features that you saw with cervical and thoracic, and they won't be there on the lumbar ones, right? Then you got your sacrum and your coccyx. So the sacrum actually starts out as 5 separate vertebrae, and around age 17, they start to fuse. The coccyx is 4 separate vertebrae, and between 20 and 30 years of age, they start to fuse. So I'm just guessing here, but it's highly likely that there are plenty of people in this room that do not have a fused coccyx, and maybe a few people that don't have a fused sacrum in here. I don't know. Anyone want to show off your sacrum and we can check? No, I'm just kidding. You don't have to show off your sacrum. But it does take a while for these to actually fuse. So again, in a younger person, you're going to have technically more than the 206 number, right? All right, that then brings us to the thoracic cage. Thoracic cage is just the name for the bones that protect your thoracic organs, like your heart and lungs, right? And, you know, there's two main categories of bones. You got the sternum, right, or your breastbone, and then you've got the ribs that are connected to it. Now, the ribs are connected to your sternum using pieces of cartilage that are called the costocartilages. I'll show you that actually here. So again, there's the sternum, and then here's the ribs, and you can see these things in front here, that's all cartilage. And cartilage is, you know, nice and flexible, and it'll like stretch and whatnot, so that's really important for when you breathe, right? When you inhale, you got to be able to expand your thoracic cavity. And by having the cartilage there, it gives a lot of stretch and it allows your thoracic cavity to expand, and you'll be able to take a nice deep breath. You know, when you get older, your lung function doesn't work as well usually as it did when you were younger. And one of the reasons for that is simply the joints between the ribs and the vertebrae, or between these pieces of cartilage in the sternum. You know, you can get joint disease there just like you can in other joints in the body. And if you don't have good range of motion on those joints, it's going to affect like how deeply you can breathe. You won't be able to inhale as deeply.
So do they get harder? Like as you get older, does
Yeah, you mean like the cartilage, or
yeah, like the cartilage?
yeah,
itself,
it
so
loses
the-
it loses a lot of its flexibility. Yeah, it becomes more stiff.
So
Yeah.
I heard about like it's random this disease that like people turn into like statues, like all
Oh,
their.
stiff man disease or
Yeah,
whatever. Was
yeah.
that, isn't that what Celine Dion has or something like that?
I swore it was like she
Or some
can
stiff
sing
person.
because like.
Yeah, like you can't take a
So-
deep breath. You can't, you know, when you sing, you got to be able to take a deep breath.
So what causes that?
I have no idea. I don't know.
Okay.
I don't know what's going on.
Like, what extra thing makes the cartilage harder? Like, is it?
It's
something
like
that
loss of
changes?
moisture. Yeah,
Okay.
loss of water. Yeah, but I don't know. I don't know exactly what's happening in that that disease
Well,
though.
with that, no, but like with cartilage in general, like getting older.
Yeah, getting older, just losing some of the moisture. Yep. Besides obviously helping you to breathe, they play a role in protecting your heart and your lungs, etc. They also provide support for the bones that we'll talk about next week that, you know, connect to your upper limbs, like your clavicle and your scapula. Sternum has three parts to it. So if you look at someone's sternum, there's this part up here, that's the manubrium. Then the main part is the body, and then the little pointy part down here is the xiphoid process. That's the thing that you can sometimes break when you're doing what? CPR. Should you stop if you break that?
No.
No, keep going. They may sue you later. I know, who knows? You know, hopefully they'll be alive. They'll save their life, and they won't be that mad. 12 pairs of ribs I mentioned, and then the costal cartilages. The word costal just means relating to the ribs. And again, it's really important that those pieces of cartilage are elastic because it'll allow the thoracic cavity to expand when you want to inhale, and that's super important. Now, just because I guess somebody thought ribs were too easy to understand, they said like, hey, let's classify them into excruciating detail to make kids really angry, or make students really angry. And they're like, perfect, that's gonna work. So what they did was they put the ribs into two groups. Either you're don't ask me how they got these names. You're either a true rib or you're a false rib, okay? A true rib or a false rib. So ribs 1 through 7 are considered true ribs, and then ribs 8 through 12 are considered false ribs, okay? So what does it take to be considered a true rib? A true rib, you basically have to have your own piece of cartilage that connects you to the sternum. So if you follow, and again, in brown is the cartilage up here. So if you follow rib 1, it's got its own cartilage, 2 has its own cartilage, 3, 4, etc. Even if you go down to 7, if you trace it, you'll see that 7 does have its own piece that does directly connect it. But if you look at ribs 8, 9, and 10, they kind of piggyback and hitch a ride on 7 in order to connect. They don't have their own dedicated piece of cartilage that takes them all the way to the sternum to connect with it. So they're considered false ribs. And then ribs 11 and 12, they don't even connect at all. So they're also considered false ribs. or if you want to even be more precise, they call those floating ribs, okay, because they don't have a connection to the sternum. Okay. All right, last but not least, some homeostatic disorders. So, a herniated disc, or a slipped disc, like they might say in layman's terms. So when you look at a intervertebral disc, it looks a hell of a lot like, this is gonna make some people hungry, a jelly donut, all right? Vertebral discs are like jelly donuts. The breading part, the part that sucks that you just want to eat through, right? The breading part on the outside would be this thing called the annulus fibrosus. And that's what's going to be made out of fibrocartilage. And it's going to be really strong, okay? Lots of fibrocartilage there. But the inside part of the disc is going to be like the jelly of the jelly donut, and that's called the nucleus pulposus. And what can happen is over time, you can get a breakdown in this annulus fibrosis that will allow the nucleus pulposus to kind of squeeze its way out. And if that break happens in the wall that's facing towards where the spinal cord is, it's completely possible for that disc to herniate and then either compress the spinal cord or compress some of the spinal nerves that are exiting in that area. And that's going to create a lot of pain for that person, either back pain, or they might experience pain like in their butt area or going down lower from there, okay? So what can you do for it? Well, you can try different things, but if you want a real fix, you'd have to do surgery, and this is the procedure that they do. I don't think there's any audio on this, so. This is called a lumbar microdiscectomy. So I'm just going to narrate this. Basically, they're showing you, usually a herniated disc is in the lumbar region because so much of your body weight's down there. Now, by the time you're in the lumbar region, you actually don't have spinal cord down there anymore. It's actually stopped earlier, but you still have nerves down in that area that could become compressed. And basically what they're showing you, that'd be the annulus fibrosis. There's the nucleus pulposus coming forward. There is an intraoperative x-ray, which frankly, I'm not really sure what they're trying to show you there, but that was that. They're making a skin incision in the midline of the back. It's bleeding a little bit, but they'll take care of that. Then they have to take like a little bone saw, and they have to cut away some of the lamina in order to see the disc. They have to cut that out of the way, and then they can go in with some instruments, and they basically just snip off that part, and then they can put some sutures in to hold the other part together. All right, so you're basically just taking the compression off. And you know, neurosurgeons do this, orthopedic surgeons do this. They can do it pretty quickly nowadays. I don't know exactly how fast it is on average. It's probably under an hour, I would say. And the incisions now can be pretty darn small, like just like barely like a centimeter or something. Yeah.
So the middle, you said it's like jelly. Is it
I mean, it's gel-like. It's not complete jelly. It's just sort of softer kind of tissue goo, if you will. It's still got some consistency to it. It won't just drip away.
I was like, why don't they just like suck it out a little?
Yeah, no, it's not. It's a little bit firmer than that. You would actually have to cut it to remove it. Yeah. All right, we're almost done here. And then last, well, not quite last, but second to last, we've got some spine disorders, some abnormal curvature. So remember, when you look at somebody from the side, it's normal to see curves, right? You should see 4 curves when you look at somebody's spine from the side. That's normal. But if you look at somebody from the front on, should you see any curves then? No. Your spine should be completely straight if you're looking at somebody front on. If it's not, if it's bent a little bit to one side or the other, that's scoliosis, all right? That's a lateral curvature of the spine. And how would you diagnose that on a person? Like what could you do on physical exam to see if they have scoliosis?
Right up your shoulder.
Yeah, so you could feel it. You could have them like bend forward and kind of look at it. You know, that can sometimes tell you. And then the other one is have them stand up and just look at their shoulders and oftentimes one shoulder will be a little bit higher than the other shoulder. All right? Sometimes it's really obvious, like in this woman it's pretty obvious, but sometimes you have much more subtle cases and it's not so easy to detect, okay? You always could, get an x-ray to do, like confirm it or whatever. Depending on how severe it is, it can cause a lot of pain. Obviously, there can be the cosmetic issue too. Just depending on how bad it is, they might not do anything at all. They might put a brace on when you're younger and try to straighten it out over time. And then in really severe cases, they might actually do surgery, go in, straighten it out, actually fuse some of the vertebral bodies together and hold them in place, okay? So there's a bunch of treatments that they could do. A kyphosis is an exaggerated curvature of the thoracic spine. And a good example of that was basically that woman that I showed you on Tuesday that had the compression fracture of the thoracic spine. And they're like, they're hunched over like this, right? That's a kyphosis. It's an excessive curvature of the thoracic spine. And then there's a lordosis, which is an excessive curvature of the lumbar spine. And that can happen in different disorders, but one of the most common people you see it in are pregnant women, okay? So when a woman's first pregnant, right, the baby's kind of small, and the body weight's going like, her center of gravity is going right down, through her spine, through her feet. Things are fine early on in the pregnancy. But then what happens? Well, then that stupid baby grows, right? And it's coming out here like this. And, obviously in some women, that baby can get huge. So what happens? It shifts the woman's center of gravity. So she's doing this, and then to compensate, what does she do? Right? She's walking like this around. And that's putting all that strain on the lumbar spine. That's hurting the lumbar spine, okay? It's exaggerating it. And so a lot of women develop lordosis when they're pregnant. It usually goes away after they deliver, but it can cause a lot of back pain. Yeah.
Is there surgery for pretty much all of these? I know scoliosis can have surgery.
Yeah, there's surgery for all of these, just depending on how severe they are and what the cause is. Obviously if you had a kyphosis due to a compression fracture, they might do that procedure I showed you guys before, where they balloon it up and kind of try to get back to height again. Yeah. Last but not least, spina bifida. This is a potentially serious disorder. This is where the bones, the vertebrae, don't close completely around the spinal cord. Okay, when you're an embryo and a fetus, as the vertebrae are developing, they should naturally enclose the spinal cord and surround it. But sometimes that doesn't happen in one area, and you get what's called spina bifida, okay? And just depending on how severe your case is, it may not even be obvious at all. For example, some people can have spina bifida occulta, and in that case, they have such a small defect that if you were to look at their back, you might only see something that looks like a little tiny freckle, and that's it. Absolutely no other symptoms, but technically speaking, they had spina bifida, right? Versus you might see somebody that looks like this, that has this big sac, which is called a meningomyelocele, on their back, and inside of that sac, you can have cerebral spinal fluid. You can actually have the spinal cord and the spinal nerves twisted and turned, and unfortunately what happens in those cases is that it usually damages the spinal cord so much that these poor kids are paraplegic. They can't move their legs, okay? So it can run the gamut from being not noticeable at all the way up to like you're not gonna be able to walk and that kind of thing. What can you do as a pregnant woman to reduce the risk of having a baby that has this? Take what?
Prenatal?
Take vitamins, yeah, specifically what vitamin? Folic acid, folate, is the one that's been associated with this. So it's well proven that if you have enough folic acid in your diet, it will significantly reduce the risk of having a child that has spina bifida. Okay. You should get the other vitamins for other reasons, but particularly for this one, folate. All right, take a break. When you come back, grab some of the microscope slides that are back there, take a look at them. There's one that says tendon on it. You can ignore the one that says tendon, but basically all the other ones you can look at. I'm going to put examples of the different bone shapes back there. You can look at that as well.